So before puberty, the hypothalamus is dormant because the GABA will keep this hypothalamus on the dormant state. At puberty, because of the main hormone, that is the kisspeptin, and other things like neurokinin and leptin is derived from the adipose tissue, and leptin will have the permissive role because of all these hormones. So these will decrease as the GABA, so the hypothalamus get activated. So from the arcuate nucleus of the hypothalamus, GnRH is released. The neurons are derived from the olfactory fluid. So this olfactory fluid will migrate into the arcuate nucleus along the olfactory nerve. So if there is an absence of the migration, it is known as Kalaman syndrome. In the Kalaman syndrome, there is no GnRH released, plus anosmia is present. So the GnRH is a decapeptide hormone. Its T-half is 3 minutes. Pulse frequency of the GnRH. Lowest pulse frequency is 1 in 4 hours, which is seen in the luteal phase. At this phase, we have the lowest levels of the LH and FSH. Next, follicular phase or the follicular phase releases the FSH in 1 in 90 minutes of the pulse frequency, and the highest pulse frequency, that is 1 in 60 minutes, it is seen in the mid cycle where the LH is released. At lowest pulse frequency, predominant is FSH. At high pulse frequency, the predominant hormone is the LH. So the application is, we have the GnRH agonists like leuprolide, goserelin, and also nafarelin and buserelin. So this GnRH agonist can be given in a continuously or the pulsatile. So if we give in a continuous, these GnRH agonists or can be given orally, can be given as a subcutaneous injection or intramuscular or the nasal spray. So this will cause, on giving the continuous GnRH agonist, there will be a ovarian suppression will occur. So how this this will increase if we give the GnRH continuous fashion, there will be increase of the FSH and LH. This because of the sustained high levels of this will have the negative feedback on the GnRH. This will suppresses the HPO axis and decreases the release of the LH, FSH and estrogen. This is known as the flare response. If we give in the pulsatile GnRH, it will causes the ovarian stimulation and it increases the LH and FSH. Indications are Kalaman syndrome and also delayed puberty and infertility where the ovarian ovulation induction is needed. Next, other group, it is a GnRH agonist. If we give continuously, it is given in the estrogen dependent conditions because these will produces the hypoestrogenic states. These are given in the fibroids, endometriosis, precocious puberty, breast cancer, prostate cancer and hirsutism, heavy menstrual bleed. And GnRH antagonist, which is more common, is cetrorelix, and newer drug is elagolix, and orally active and more expensive. There will be no flare response, and only one thing, it will cause the ovarian suppression. It is GnRH antagonist or FDA approved for the fibroid and endometriosis. So the puberty, at the time of puberty, there will be a pulsatile release of the GnRH. Because of the pulsatile release, it will produce as the pulses of the LH, and after that it produces the pulses of FSH. Initially the pulses are produced only at night time. Because they are produced at night time, these LH and FSH are not released regularly. So initial cycles are anovulatory. After 1 to 3 years, there will be a pulsatile release of both hormones at night and also at the daytime. That's why ovary is stimulated and secondary sexual characters are produced. So average, if we see the normal thing, average onset of the puberty in girls, it is 10.5 years. Next, in boys, it is 11.5 years. It is termed as precocious puberty in girls if there is no development of the puberty, that is stellar, at less than 8 years. There is no testicular development at a below 9 years, and delayed it is termed as if it is more no signs of any sexual characters more than 13 years, if there is no signs of any sexual character more than 14 years. The first visible signs of first sign of puberty in girls, it is the growth spurt, and but the first visible sign it is telarc, that is more than 2 of the Thanos stage. Next, after Telak, puberty will occur because of the androgens. Next, it is a peak height velocity, which is a Thanos stage will be 3 for the breast and pubic hair. After peak height velocity of 6 months, we can menarche will start. Average age is 12.5 years. Precocious menarche is termed as if it is less than 10 years. In boys, the first sign is testicular enlargement, that is increasing testicular size and also the volume. And first visible thing it is the penile enlargement, and next puberty will occur, next peak velocity. So in girls it is firstly the growth spurt, after growth spurt it is the telarc, next puberty, after puberty peak height velocity, next will be the menarche. In boys, it is the testicular development, later it is penile development and puberty and peak height velocity. So what are the problems of the normal puberty? It will be acne and abnormal uterine bleeding. The common cause of the abnormal uterine bleeding is 80%. It is the anovulation, that is cycles are irregular and heavy bleeding is present. And second most common is the coagulopathy. So coagulation profile need to be done. And the important thing is pregnancy and its complication also causes the heavy bleeding. So first we always rule of the pregnancy. Other causes of abnormal uterine bleeding is the thyroid dysfunction. If in the case scenario 16 years old girl comes with the irregular and heavy bleeding. So if the bleeding is mild, that is HB is normal and it is physiological, wait and watch. Give the NSAIDs, that is mefenamic acid and Trenexa. Trenexa it is antifibrinolytic. If moderate to heavy bleeding is present, HB is fallen, and drug of choice is OCPs, because estrogen and progesterone will have the negative feedback on the LH and FSH, will cause the ovarian suppression. So OCPs are given in a 1 to 21 days it is a hormonal, and last 7 days it is a non-hormonal. OCPs will causes the cycles regular and also decreases the menstrual bleeding. So why? Because as the OCP will causes the thinning of the endometrium. So it also avoid the unintended pregnancy, acts as a contraceptive. Other it is, if we give only progesterone instead of estrogen plus progesterone pills, the progesterone only pill will have the poor compliance and side effects are present. If the girl refuses the hormones, alternative method it is give the Trenexa and mefenamic acid. But these can't regularize the cycles, only they will decrease as the bleeding. In other case scenario where 15 years old girl presents with the bleeding heavily or continuously for 15 days. Because it is bleeding heavily, that is continuously for 15 days, the endometrium will become thin. Thin of endometrium means endometrium is not primed. So progesterone won't help in this situation. So if patient is stable, first she need estrogen. So high oral dose of estrogen is given. After when the bleeding will stop, because this estrogen will causes the endometrial proliferation and bleeding will stop. Add the progesterone. So it can be given as an OCPs. So treatment can be OCPs, that is 3 to 4 pills per day. If bleeding stops, give 3 pills, next 2 pills, next 1 pill per day for 21 days. If she is unstable, give the IV estrogen. So IV estrogen is only reserved for girls with unstable vitals, and DNC should not be done for pubertal girls with abnormal uterine bleeding. So after when the bleeding will stop, give the OCPs. Next, puberty changes. So puberty abnormalities are, if we look the telarc, which is the first visible sign of the puberty, if it is less than 8 years, it is termed as a precocious puberty. If telarc takes time of more than 13 years, it is termed as a delayed puberty. Precocious puberty is more common in the girls and delayed puberty is more common in the boys. So most common cause is for the delayed puberty is the constitutional delay. Family history is present. In girls, it is a gonadal dysgenesis. In girls, constitutional delay is diagnosis of exclusion. So the most common cause of delayed puberty is the constitutional delay. We have the precocious puberty. Two types of precocious puberties are present. Central is more common than peripheral. So central, it is because of the premature activation of the HPO axis. Most common cause is idiopathic. Up to 10% it is the brain tumors. So most common brain tumor, it is a hypothalamic hematomas and pineoblastoma, glioblastoma and meningiomas. Then peripheral, it is HP axis is dormant and there will be a peripheral source of sex hormone will cause us the pubertal change. All girls with a precocious puberty should undergo the neuroimaging, that is MRI. Next, the peripheral causes of the peripheral precocious puberties are ovarian tumor, adrenal tumor, congenital adrenal hyperplasia and McCune-Albright syndrome, that is a triad of the precocious puberty, cephaloid spots and polycystic fibrous dysplasias and long-standing severe hypothyroid, that is high levels of the TSH will stimulate resembles the alpha subunit of LH, so it will stimulate the ovary. Next, we have the how to differentiate the central and peripheral precocious puberty. So the central precocious puberty, the FSH levels are the pubertal range, and in the peripheral precocious puberty, it is of prepubertal range, and we have to do the GnRH stimulation test. So central precocious puberty always corresponds to genetic sex, that is original sex, and treatment of choice for central precocious puberty, it is of so in general, if they ask the treatment of choice for the precocious puberty, more commonly it is a central now, so we have to give the GnRH agonist in a continuous fashion. Treatment for the peripheral precocious puberty, treat the underlying cause.